Hi, I'm Dr. Rebecca Nystrom here with old-fashioned X-rays, keeping it real. I want you guys to remember that there's something different that happens in your brain when you actually manually mark an X-ray than when you do it on a digital X-ray, than when you just try to look at something and figure out what the listing is. So what you're doing on an X-ray, unless you're a DACPA or a radiologist, and if you do a structural technique, you are going to translate what you're seeing and drawing on the X-ray into muscle memory, so that when it comes to adjusting that segment, it's already in there in your brain. It's also in your hands. So let's begin. We're starting with an AP and lateral lumbopelvic view. Here's the lumbar view. We're going to count the vertebra, starting with the sacrum. So this is basically S1, L5, 4, 3, 2, 1. Now, most of the films that you'll see in this series are actually full spine films cut up so that you can see the individual pieces. I highly recommend that you take full spine films, and even if you use digital, you do a good digital machine that can either knit the two together or that allows you to do it. The reason we put the numbers on the body of the vertebra instead of the disc space is A, you want to see the disc space, and B, things tend to grow in the cavities. So keep the disc spaces clear. Okay, so this is the sacrum and the lumbars. And if we were to say anything about this, I would say that this is a slight increase in lordosis. Okay, so now let's start with this one. So again, here's 5, 4, 3, 2, 1 is up there. And I'm using this film. Unfortunately, you don't see all the lumbars, but I'm teaching you pelvis now. Okay, now we're going to do the dots. Okay, so the first 2 dots are going to be the tops of the femur heads. And try to have the dots in the same place. Now we're doing the tops of the iliac crest. Again, in the same place. Now do the most lateral margin of the sacrum, and again, in the same place. Now do S1. While you are noticing S1, also notice the other tubercles and see if there is distortion. So here's S1, here's S2, here's S3. So we want to make a note that S1 is slightly right. This is the right side of the film. This is the left. I like to look at my films like how I look at a patient. So I'm looking at the patient from the back, and I don't want my brain to have to switch those around. So as I look at a patient, the right side's on the right side. As I look at the film, the right side's on the right side. Okay, a dot in the pubis symphysis, a dot at the most inferior point on the ischial tuberosities. Note the shape of the obturators. And a dot where the illa meets the facet, right here. Okay, I think we're ready. So now, this is called a Gonstead parallel. I suggest you get the real thing. They last forever and they work really well. Okay, so we're going to start with the femur head lines. I'm sorry, this is going to tip for a second. And you connect the dots. This is the only line that's actually going to cross the cavity. Okay, now I'm going to roll up until I hit the lowest dot, which is right here, a little higher for this one. And I'm going to roll down. I'm going to check again. Okay, and I'm going to measure those two spaces. So this is 217, and this one is 216. Now I'm going to put my parallel so that it is perpendicular with the femur headline. Line it up to, now this is interesting because this is the dot on S1 and this is the dot on S2. For me, because S2 and S3 are in the same place, I'm thinking that maybe it's one that's distorted, but I don't know right now. So I'm going to use S1 and I'm going to draw a line across the pubis symphysis. Okay, from this dot to that line, we have about 3. It's about 3. Okay, so those are the iliums. We have a slight increased lordosis. So if there's an increased lordosis, you're going to have, that will correlate to either PI ilium or an EX ilium. And sometimes you can have a PI EX ilium. But a PI and or an EX will increase the lordosis. An AS or an IN will decrease the lordosis. So I'm going to list the side that is a PI, and hopefully it's also an EX, which in this case it is. So this is actually a PI1, right? 217, 216, and an EX3. So that's the listing for the ilium. Please remember, listings are not the same things as subluxations. Listings are just a roadmap. Okay, now let's look at the sacrum. So I'm going to draw a line through the illa. This is your femur headline. This is like your sacral baseline. They're basically the same thing. I'm going to use the sacral line and connect it to the most lateral margin of the sacrum on that side and on that side. And let's see where we ended up. So using S2, we're at 60 here and it's 64 here. So this is a 4 right. But now let's look at something just for interest. Let's start at the top so we're even. Calm down. Interesting. It's still about the same. So even though these look distorted, it's not as distorted as it looks because the measurement is 3.5 as opposed to 4. So remember that when the cerebral spinal fluid is still moving, somebody can go into a Kundalini wave. The tubercles of the sacrum can fan open. And for those of you that practice techniques that increase cerebral spinal fluid and are looking or contributing to the wave, you should start to feel that those sacral tubercles will start to open up. And even if you don't do those sorts of techniques and you're doing mainly just structural techniques, you will find that after a patient gets a certain amount of fluidity, a certain amount of flexibility in their pelvis, that the ossicles will have, the tubercles will have a bit more movement of their own. And sometimes you have to treat them like individual segments. Okay, I think we're good with this. Thank you so much.